Thank you very much. That was a great advertisement for Michigan Open, and I wasn't anticipating that, and I probably should pay for that. I'm Chad Brummett. I'm from the University of Michigan. I'm going to just give you a snapshot on what we've been doing in Michigan and talk a little bit about risk in particular. I do have some funding from the National Institutes of Health, Michigan Department of Health and Human Services, SAMHSA, the CDC, all directly related to the work I'll show you today. I have an unrelated patent, and I do consult for Heron Therapeutics. I won't discuss their product at all today. So our group came together about 3 years ago to address the opioid epidemic, but in a different way. We felt that there was a lot of focus on medication-assisted treatment, chronic pain, what to do with the chronic opioid user. And while these are definitely important topics, really, if we went back and thought about it, 90% of the people coming into your ORs each day are opioid naive, and at that time, no one was really talking about what to do with that population and really thinking about whether that was important. And I think we just heard that it is an important topic, but if we really think about preventative medicine, and we heard that from the first lecture, prevention matters. Well, early on in our effort, we wanted to understand how many people go down that path of a new chronic user. So these are claims data, using claims data, people not using opioids in the year prior, how many keep refilling past what would be deemed normal surgical recovery? And this is probably the article for which we got the biggest splash. About 6% of patients undergoing both minor and major surgical conditions and things that you guys do continued to be opioid users, and there was no difference between major and minor surgery. I wasn't surprised by that because we had analyzed secondary data from our prospectively collected knee and hip replacement data showing that 4% of the hips and 8% of the knees kept using long past recovery, and there was no difference whether their knee or hip got better or worse or stayed the same. So this concept resonated. 13% in hands, 13% in spine surgery, 4.8% of teens and adolescents undergoing elective pediatric surgery. Our cancer exception is probably a problem, right? So we talk about where could we make improvements. In cancer surgery, and I'll take that 10% number, surgery is very comparable to that 6% number and yet a higher rate. Well, I think as providers, we're more liberal in our prescribing with cancer patients, and I also believe cancer patients are more likely to take those pills. But that 10% number, those were curative cancer surgeries. So what factors were associated? I mean, this is really what I was asked to speak about today. Well, these are the things that we see pop up. Other chronic pain conditions. So I come in, I've got knee or back pain. My primary care physician is doing a better job of not prescribing opioids because we know the long-term data show that they will not benefit that patient in most cases, and the risk-benefit ratio is poor. But I get them for my abdominal surgery, and I keep taking them for other conditions. Anxiety and depression are distinct. Anxiety is a big factor, and I'll talk more about that in a minute, but certainly associated. Previous substance use history and tobacco use, we really need to understand that we have to do a better job of assessing patients' substance use history before surgery. It's something, respectfully, even in our own health institution, despite the fact that we've been in this space for a long time, we don't do a great job of assessing for opioid use disorder, heroin use, alcohol use. I mean, we have to really understand what risk for these patients. And then I think beyond just the individual patient risk, your prescribing pattern matters. And while this is about third molar extraction, I think this was one of our first studies where we really showed that just receiving a prescription mattered. Dentists and oral surgeons have known for a long time that acetaminophen and ibuprofen are actually superior to opioids for treating third molar extraction pain or any dental extraction pain. And yet after adjusting for patient characteristics, including demographics, psychiatric comorbidities, medical comorbidities, and pain diagnoses, and the impaction status of the tooth, there was an associated 2.7 times increased risk of becoming a new chronic user just by filling the opioid. So that exposure matters. We've now seen several surgical studies since showing similar factors. And beyond just getting a script, how much you prescribe matters. And these were data from that were just shown. This is from Ryan Howard, one of our fellows, one of our surgery interns. We now these were published in JAMA Surgery last year. We looked at lap chole prescribing. We prescribed about 50 pills. For those that feel shocked, at the end of 2017 in Truven, the average is still 42 pills. 6 pills was the median use. And so early on in our efforts, and this was very early, we were very conservative, we went from 50 to 15, and as was showed in the previous slide, 15 became our new average without any change in refills, pain. But as we prescribed less, people took less. Now, I'm not going to beat the podium and say that 2 pills for lap chole matters, But if we project that out to more painful surgery where more opioids are used, the amount you prescribe matters. And Ryan followed this up with statewide data. And one of the strongest predictors of how much opioid a person used after discharge was the amount prescribed, such that for every additional pill prescribed, patients used an adjusted half pill more. So you give them an extra 20 pills. After adjusting for all their patient factors, they're going to use an extra 10 just because you gave them more. And we've now replicated that in knee and hip, and the effect size is exactly the same. It's quite striking. This is the supersize phenomenon. This is a very common social psychology construct. This is called anchoring and adjustment. You are anchoring patients further down the stream of opioid use by giving them enough so they don't run out. We've all heard it. Many of you have taught it. I taught it. I'm part of the opioid epidemic, right? I did this, right? Because I thought I was giving good care, but just giving them enough so they don't run out or giving them 90 pills for convenience isn't going to decrease refill rate. It's not going to improve satisfaction. It's not going to improve pain. What it will do is increase their use and their potential for long-term ill effects. Many of you know that we work across the state. We work in a very unique network of surgical collaboratives funded by Blue Cross Blue Shield of Michigan. As we speak, the MSQC and Aspire are meeting in Michigan today. This is our largest meeting to date. All 73 hospitals around our state actually meeting together to talk about quality. We have, in Michigan Open, superimposed an opioid narrative across this collaborative and many other collaboratives in our state, where we're getting real-world prescribing data. So we not only get the prescribing, but consumption. And from that, we've made recs. We made initial recs in October of 2017. They were the first evidence-based prescribing recs from 35 hospitals. We now have about 10,000 patients with patient-reported outcome. And these are our new recs that are just now up on our website. You don't need to take a picture because if you laminate them and put them on your wall, they're going to be obsolete in 6 months. We have updated these 3 times. They are really about patient-reported outcome data. And we see no change in pain or satisfaction based on the reductions, while we do see massive changes happening across our state. Maybe even a 50% reduction across our state in the last 10,000 patients assessed without any ill effect. We're still interested in these high-risk patients, right? So it's not just about opioid-naive patients, and these are the first 35,000 patients in our biorepository. This study was published in JAMA Surgery last year. About 20% of the patients coming into this surgical initiative, we're a perioperative initiative where we collect a blood sample for future use for biorepository efforts. 20% were using their opioids, and certainly we saw more orthopedic surgery, more pelvic surgery, kind of the things you would expect. And opioid users were sicker, they had more sleep apnea, more psychological distress, and more widespread pain, kind of what you don't want in an opioid user. Well, we're excited because through that initiative, which is now about 65,000 patients, we recruit about 10,000 a year, we know about 80% are opioid naive. Just this week, we've linked their health record, their PDMP data. We've actually replaced the SureScripts data with our prescription drug monitoring program data and their genetics data. And we're going to ask this question: is there an association between that prescription they receive perioperatively and their genetic makeup? Now, I don't know that this will be important for prediction, but it might tell us about biology, and we're excited about this work. You know, the first box there, this eliminate unnecessary exposure, our group has largely focused on reducing from really high, excessively high numbers to less. But if I was to tell you what we're doing this year and where we believe bold change is happening, it's exactly what's happening in this panel. We need to be looking around not just at where we can go from a lot to a little or a lot to a lot less. We need to look around and ask, well, where are those cases for which we shouldn't be prescribing at all? Where in any other country in the world, patients do very well but receive no scripts, and I think we heard that very well in our last lecture. And I will say, we can do this in a way that manages pain and enables recovery. And to that point, just in terms of practical tips, I would strongly encourage basic education. Telling people surgery hurts will help. Just telling them that. Encouraging acetaminophen and ibuprofen, really important. We know that patients just don't take them because you can buy them over the counter, so they must not work. You really want to avoid co-prescribing benzodiazepines. Right? Don't acutely wean people, but this is a problem. And prescription drug monitoring programs may seem cumbersome, but they are not controversial. They are absolutely appropriate, and if you're not using it, you should be. I will put a plug in for my 2 colleagues, Afton Hassett, a psychologist, and Jen Walge, a co-director of Michigan Open and a surgeon, really trying to say anxiety, while we know anxious patients will use more opioids, that's probably not good. And simply giving them more opioids is not the right answer. So let's treat anxiety the right way. And this is a grant. This is for a grant they're in the process of resubmitting. They will take people down a path that truly actually addresses anxiety in an appropriate way. And I'm excited about this work. For those times where you do prescribe an opioid, a last little tip to leave you with, only prescribe one short-acting opioid. Don't prescribe multiple. We see this more in orthopedic surgery, but we see it in all surgical conditions. Don't give long-acting opioids to people who are otherwise opioid naive. Don't give people a script before the day of surgery as a convenience. Those people go to have a higher rate of new persistent use and poorer outcomes. And I have it in my bag down there. I carry naloxone everywhere, and your patients that are high risk should carry naloxone. I want to give credit to my colleagues. Mike Inglesby is a transplant surgeon and one of the co-directors of Michigan Open. He also runs medical education. And Jen Walsh, he's a health services researcher, surgeon, plastic surgeon, hand surgeon. And this is our team. And with that, I will thank you for your attention.
Yeah, perfect. Thank you.